This is Tropical Cardiac Diseases, and I'm Matt Lyon. Our learning objectives are to use ultrasound to diagnose and evaluate various cardiac tropical diseases. And we also would like to cite how to use ultrasound as an adjunct to monitor tropical cardiac diseases in their progression, as well as monitoring after treatment. Our first disease is Chagas disease. Chagas disease has two phases, both acute and chronic, and ultrasound can be used for both of these phases. Ultrasound is complementary to the EKG and shows the cardiac structure as well as function and correlates it to the underlying pathophysiology of Chagas disease. The acute phase of Chagas is often unnoticed, and Chagastic myocarditis is infrequent, affecting only 1 to 5 in 10,000 people. When it does affect the heart, acute Chagas most often leads to a pericardial effusion. This occurs in about 42% of the time. The pericardial effusion may be large and often leads to tamponade. This can be a life-threatening emergency, and we've seen in prior lectures how ultrasound can be used to diagnose pericardial effusion and pericardial tamponade. In the acute phase, the LVEF is almost always normal, and there may be some apical or anterior dyskinesis, but this is rare, occurring only in about 20% of the patients. Even more rare is LV dilation, which occurs in only about 6% of the patients. So ultrasound can be used in the acute phase when somebody comes in and they're quite ill. The most common thing you're going to find is a pericardial effusion, and you need to evaluate for pericardial tamponade. In the chronic phase, ultrasound is more important. As the disease progresses and becomes chronic, it is characterized by a diffuse and patchy chronic myocarditis. This myocarditis leads to myocardial fibrodestruction with fibrotic replacement. As the myocardium is replaced by fibrotic tissue, the heart becomes very stiff and dilated. And at autopsy, almost all the hearts evaluated after chronic phase of Chagas are grossly enlarged. There is often frequently an apical aneurysm that is associated with the chronic phase of Chagas disease. As Chagas disease progresses in this chronic phase, there is progressively increasing fibrosis of the endocardium. This leads to more symptoms as well as more findings in EKG and ultrasound evaluations. If we use the ACC-AHA staging classification, there are 4 criteria. A is the earliest stage with very limited fibrosis of the endocardium. As such, there is very little structural disease, and the EKG is normal. The echo is also normal, and the survival at 5 years is very good, with 98% of the patients still being alive. As we go to B, there is more fibrotic replacement. The EKG becomes abnormal, thus defining stage B, with right bundle branch blocks being most common, as well as left anterior fascicular blocks. You also begin to have arrhythmias such as PVCs. The echo findings are almost always normal. There may be some evidence of an LV aneurysm or LV lesions, but almost always the LV fraction is normal. There may be the beginning of some diastolic dysfunction, which we will talk about in a few minutes, but the survival here is still very good. Ultrasound becomes more important in the later stages of the disease, C and D. Here, we know that the EKG is abnormal, with increasing amounts of blocks as well as arrhythmias. The heart size begins to increase, and the patients start to have more heart failure. The heart size increases, the percent of patients with LV aneurysm increases, and the number of lesions increases. There is also a decrease in ejection fraction to correspond with the increased CHF. We also start to see more diastolic dysfunction. And as we go from C to D, the heart failure becomes refractory. That's the definition between C and D. And when this occurs, the mortality rate increases drastically, and the 5-year survival is less than 30%. Here we have a couple pictures of Chagastic aneurysms. These are LV aneurysms. The picture on the left is one of the classic pictures from the journals, and it shows dilation of the apex of the LV. On the right, we can see a cine loop of the same type of aneurysm at the LV. This is an apical 2 chamber. We can see how the apex, instead of coming to a point, is fairly broad and dilated, and it also has some thrombus in it. Tissue Doppler imaging can be very useful in chronic Chagas cardiomyopathy. We haven't talked much about that in prior lectures, so I will not go into it very deeply. But you can use tissue Doppler imaging to determine the velocity or the lengthening of the myocardial fibers. This is more sensitive for detection of early disease than normal EKGs and 2D echo. As the disease progresses, you'll be able to demonstrate abnormal LV systolic function contraction times, and in diastole, there will be impaired ventricular relaxation and impaired diastolic filling. These diastolic abnormalities often precede the systolic abnormalities, as well as precede the EKG findings. So therefore, it is very useful in the earlier stages of disease. However, this is a complicated technique, and some machines that are used in the developing world aren't capable of doing this function. Therefore, we'll leave this for future lectures. So in summary of Chagas, ultrasound can be used for both the acute phase as well as the chronic phase. But if we think about it in our patient care areas, and we go into a new environment and we have a sick patient, we can use it immediately. And this is most often for detection of pericardial effusion and then determination if that effusion is tamponade. If it is, then this needs to be treated. We can also use it more of the chronic phase in diagnosis and staging, and we can look for detection of apical aneurysms, detection of thrombus, detection of dilatation, and grading of the severity of Chagas. If we're going to be in a place for a longer period of time and we can provide longitudinal care, we can use ultrasound to establish a baseline echo. Then we can assess for disease progression. This is particularly useful in looking at the LVEF and the LV end diastolic diameter. If these are worsening, then the disease is continuing to progress. We can also use this to monitor response to vasodilatory therapy, as well as monitor progression of the Chagas cardiomyopathy after we've treated with antiparasitic medications. Endomyocardial fibrosis is an idiopathic disease and it results in a restrictive cardiomyopathy. The underlying process is produced by patchy fibrosis of the endocardial surface of the heart. This leads to a reduced compliance as well as an increased stiffness of the ventricles, which produces this restrictive physiology characterizing endomyocardial fibrosis. Interestingly, the apices of both the right and left ventricles can become obliterated through this disease, and it helps make the diagnosis. There can also be tethering of the papillary muscles leading to tricuspid and mitral regurgitation. Because endomyocardial fibrosis is insidious, it often presents in the late stages. So most patients have extensive disease at the time of presentation. And since it is an advanced disease at the time of presentation, overall prognosis is poor. The prognosis, though, depends on the extent and the distribution of the disease within the chambers and the valves. With the disease, there is progressive heart failure and arrhythmias, and these can lead to sudden cardiac death. Echo is very useful in that it helps you differentiate EMF, which has no therapy, from other processes which may have therapy, such as rheumatic heart disease, congenital heart disease, and ischemic cardiomyopathy. Ultrasound can also help you locate the fibrosis, thus making the disease. Typically, you see thickening of the inferior and basal LV segments, and the ventricles often are laden with thrombi. Again, you will probably see apical obliteration from these thrombi, which helps you make the diagnosis of endomyocardial fibrosis. Pericardial effusions can be present and are often large, and they may lead to tamponade. You will also see a restrictive filling pattern of the LV if you look at the mitral inflow or the aortic outflow. So staging is based on ultrasound findings. With staging, we look for the diagnosis with either two major or one major and one minor criteria. Then you can calculate a score to help you know whether it's mild EMF with a score of less than 8, moderate EMF with a score of 8 to 15, or severe EMF with a score greater than 15. Major criteria involve EMS plaques greater than 2 millimeters thickness, which we'll see in a minute, thin EMF plaques affecting more than one ventricular wall, obliteration of the right ventricle or the left ventricular apex, thrombus or spontaneous contrast without severe ventricular dysfunction, retraction of the RV apex, or AV valve dysfunction. And the score here will depend on how bad the dysfunction is. Minor criteria are similar to major but less severe. Thin EMF plaques located in one ventricular wall, restricted flow pattern across the mitral valve to tricuspid valve, thickening of the anterior mitral leaflet, enlarged atrium with a normal-sized ventricle, changes to the interventricular septum and the posterior wall, and enhanced density of the moderator band or other IV bands. Here are some examples. Here we see thickening of the endomyocardium. You can see that the septum of both the right ventricle and the left ventricle is thickened and bulging. Here we see fibrosis of the papillary muscle and the posterior valve leaflet. On the picture on the left, this is a parasternal long axis view, so we're looking at the left ventricle, and the left ventricle has a poor EF. If we looked at the mitral valve itself, the leaflet is somewhat thick, but the papillary muscle is very thick. Picture on the right, we see another parasternal long axis view. The posterior leaflet is somewhat thick. It's also tethered. It is not fully closing with contractions. It is remaining open. If we put a Doppler across this, we would see that there would be some regurgitation across the mitral valve. And the papillary muscle is also thickened. Here we see infiltrate of the LV apex. This infiltrate is echolucent, so it looks hypoechoic, but this is an infiltrated apex, and the apex has become thick. This is characteristic of EMF. And here is obliteration of both the ventricles. As you can see, there is plaques and thrombi filling both ventricles. They're hyperechoic, and there's less cavity size to fill with blood. And here's a left ventricular thrombus. If we put Doppler signal across the mitral valve, we can see that there is mitral regurgitation, as evidenced by the blue regurgitant jet across the mitral valve. And in case you didn't know what a moderator band was, the moderator band is in the right ventricle. It's a hyperechoic structure coming across near the apex. It is generally hyperechoic, but in this case, this band is too hyperechoic or too thickened and is easily seen. This is an end-stage EMF patient. This is a subcostal view. The right ventricle is very enlarged with spontaneous contrast as well as a thrombus. And the LV is being pushed or squeezed, not allowing good blood flow because the RV is so large. This is an end-stage patient. Pericarditis is another entity that is commonly found in the developing world. There are several types of acute pericarditis: viral, bacterial, fungal, and parasitic infections. For this talk, we're going to focus in on tuberculosis. Pericarditis due to tuberculosis is common in endemic areas. TB accounts for 50 to 75% of the cases of pericarditis in endemic locations. In endemic locations, in patients that have HIV infections, pericarditis is almost always due to TB. In fact, in sub-Saharan Africa, where TB is endemic, if a patient has HIV, pericardial effusion is one of the earliest presenting features. There are 4 phases of tuberculosis pericarditis. The first phase is a fibrinous exudation. Second phase is when it turns to a pericardial effusion. The third phase is absorption of the fusion with granulomatous caseation and pericardial thickening. This thickening leads to scarring and constrictive pericarditis in phase 4. Echo is one of the most important tools to confirm an effusion. We've talked about this before, but echo can show you the characteristics of the fluid. Therefore, you can see the fibrinous strands in the fusion as we see on the left, as well as the more caseous pleural effusion and thickening of the pericardium that we see on the right. These are classic findings. If you see pericardial effusions with fibrin or caseation in an endemic location, it is almost always due to TB. If you see fibrin or caseous pleural effusions in an endemic location, these are almost always due to TB. Constrictive pericarditis can be diagnosed using ultrasound. The way we do this is we look at the flow across the mitral valve. The flow across the mitral valve should remain fairly constant during inspiration and exhalation. But because there is a fibrinous, rigid structure around the heart, when the person takes a deep breath, the heart cannot fill and there's a decrease in cardiac output. This leads to decreased flow or velocity across the mitral valve. Any decrease of more than 25% due to respiratory variation is consistent with a constrictive pericarditis. You may also see this change in flow when there is a pericardial effusion. Pericardial tamponade, in essence, is like a restrictive or constrictive pericarditis, and as such will also demonstrate this change in mitral velocity with respirations. So when there is not a pericardial effusion, however there is a change in the mitral inflow with respirations, you must start thinking that this is a constrictive pericarditis, and in the right setting and the right location, this is going to be due to TB. Constrictive pericarditis is a poor prognostic sign for the patient with tuberculosis pericarditis. Here we see a caseous pericardial effusion. This is towards the end stage of pericarditis and will turn into constrictive pericarditis. Therefore, if you see a pericardial effusion, treatment should begin immediately in the patient you suspect has TB pericarditis to prevent this from progressing, becoming caseous, and subsequently constrictive pericarditis. Cardiac masses are also commonly found in the developing world on ultrasound. Out of these, a thrombus is the most common. You suspect a thrombus in certain diseases, as we've talked about before, but you also see it when there is any dilation of the ventricles or the atrium. The way you diagnose a thrombus is first being able to see it. Here we see a thrombus in the left ventricle of this apical four-chamber view. It can be difficult sometimes to determine a thrombus from other cardiac entities, but if you can detect it, if you see layering in the walls of the thrombus, then you can feel fairly confident that it's a thrombus. This image doesn't show that, so it's difficult to give you a good idea of what this looks like. Atrial myxoma can be confused with a thrombus. Almost always the atrial myxoma is going to be in the atrium. The left atrium most consistently, 75% of the time. The right atrium, much less. These are very smooth-walled tumors. You can see the one on the left is very smooth-walled. Occasionally you can see the stalk where it's attaching. The one on the right you can see is very difficult to see, but it is in the right atrium, a very dilated right atrium, in this apical four-chamber view. This one was difficult to diagnose. It had to go to cardiac CT to help make the diagnosis, but in this case this was an atrial myxoma. And atrial myxomas can also embolize 30 to 40% of the time. So if you see embolic disease, it doesn't necessarily mean that it was a thrombus. It could have been a cardiac tumor. Endocarditis is also very common in the developing world. When you see left-sided disease, you think rheumatic heart disease. Right-sided disease, you think of IV drug use. The TTE is not very sensitive for detecting endocarditis. The sensitivity at best is about 65%, and with new users it's probably much less than that. However, when you do see a mass, it's often fairly large and the specificity increases greatly. If you look at the Duke's criteria for diagnosing an infective endocarditis, a couple of the major criteria are based on ultrasound findings. These include an oscillating intracardiac mass on a valve or supporting structures in the path of a regurgitant jet, or new valvular regurgitation, which is not known before. So here we see, on the left, we see an apical four-chamber view. So this is the tricuspid valve we're looking at, and you can see that there's a regurgitant jet. On the picture on the right, this is also an apical view, and we can see the tricuspid valve, and we see a mass on the valve, the tricuspid valve, and it is moving to and fro with heart movements. So you can see that it is independent of the valve motion. So in conclusion, ultrasound can be very useful in the diagnosis of many tropical cardiac diseases. It has a direct effect on clinical practice in that it can be used for staging as well as diagnosing these diseases, and it can be used in the long-term care of many tropical cardiac diseases. Thank you very much. Tropical cardiac diseases.